I want to follow up on two of the questions. Just the insurance question is really important. I think I was over here. Both our office and Oakleaf do add a code for the robot. I think it's $700. If it's not covered by insurance, they write it off. So the patient won't be billed if their insurance company doesn't cover it. Some insurances like Medicare, I think they pay an extra $90 or an extra $100 or something like that. So that shouldn't be something that inhibits them. And lastly, I think the question was the same question for tourniquet, right? I like both those questions. I don't do partial knee replacements. I refer those to Dr. Crow or one of my other partners who does. And I think there's no place for a tourniquet arthroplasty, knee arthroplasty anymore. I only use it when it's cementing, and I think that's critical for total knee rehab as well as partial knee rehab. So just to finish up on those two questions, which I thought were very good. I want to reiterate what Dr. Crow said. I thank all of you for coming. What we're trying to do here would be impossible without the support of physical therapists throughout the region who are interested in helping us with this program. So without your understanding, interest, and enthusiasm, we can't possibly have people going home as quick as they are feeling like they can without this cooperation. So your coming here is really integral. I got up this morning and, like a lot of people, I reviewed my talk and I realized at the last minute I was missing probably one of the most important points, and so I'm going to tell you that before I get into the slides. And that is, why? Why do this? Why, Oakleaf is actually a really nice place to stay. If you have surgery, you can stay. You can stay here for days, and the food is good, and the rooms are really nice, and the nurses are very nice. And our therapy people are great. And so there's really no reason to go home in a hurry. The reason we're doing this is entirely driven by patient satisfaction. So we don't want people to leave the hospital because it saves money. It certainly doesn't make us any money if they go home sooner. We want people to go home when they want to because they feel great and they feel like going home. And this is actually driven by a few of my patients who are also friends who I came up to see after surgery. I'm like, how are you doing? Like, I'm doing great. Can I go? And it's like the day of surgery, and you're like, well, nothing's ready. You don't have your post-op appointments. You don't have your therapy scheduled. You don't have your equipment. So we're doing this for patient satisfaction. So that's the drive of, we want people to feel better sooner, and going home is a side effect of that, not the goal of that, really. So I want to get that. Now we're going to the how. That was sort of the why. So I want to get the why out since I didn't even put that in my talk. You got that,
trying to get that.
Oh, hey.
It gets mad when you try and go back.
Okay, so you're setting it up to take a minute to go. And so after this, actually, I'm going to talk, and then Amy is going to talk about the physical therapy part, which is really important. And then afterwards, I'll be here. I think Dr. Crow will probably still be here, right, Dr. Crow? And we can answer a lot of questions. And I'm also going to give people, if you've never seen the building and you want to see a tour, we can kind of give you a tour of Oakleaf so you can see what physically the place looks like. So that's going to happen afterwards. Any questions while we're waiting for the computer to come up, or you've got it going? It'll take a minute.
I might have to. It's working over on that side.
That's actually tricky. You couldn't probably get it to work on one side and not the other, even if you tried. Huh? Yeah, exactly. It's only a partial presentation. So, I mean, worst comes to worst, I could just go off of that one, but you think this one will come back?
Eventually, yes.
Okay.
But yeah.
Good.
Dr. Stewart?
Yes.
You can talk a little bit on standardized outcomes. What are we using?
You mean to try to measure outcomes after surgery? That's a good question. Right now, I use something called the Oxford, which is a 12-question set for both hip and knee, and it's pretty good for moderate function assessment. So it actually doesn't have a functional component, right? I don't have to measure anything, but in terms of patient expectation, it's kind of like you're a community person, you have a hip replacement, you go back to your ordinary life. We've toyed a little bit with, there's a UCLA score for hip arthroscopy patients, which we're not talking about today, but I do hip arthroscopy. So the functional score we use now comes from an Oxford. It's good for arthroplasty. It's been validated for lots of hip replacement, knee replacement patients, other major surgeries about the hip and knee. But we haven't gone to the sort of the finer ones, like for we get to sports and other things. That's more like a UCLA hip score, but we don't use that routinely. It's a good question, though.
Yeah, because what are you seeing across, why don't we follow Virginia Mason? Why don't we follow the Cleveland Clinic? So we all have standardized data so we can compare apples to apples.
So how does that come about? Why do we have joint registries, of which Oakleaf joined a few years ago? And they have very limited data. They're looking at, have you had a revision? Did you get an infection? So, but functional outcome scores, there's quite a few out there. The Harris Hip score goes back to like the 60s, and that was popular. There are some ones that came from Charnley that had to do with, can you get on the bus? Like, how many people get on the bus anymore? So, I mean, coming together on one score would be great. And where does that come from? You know, our academy, the American Academy of Orthopedic Surgeons, is pushing for scores, but they haven't picked one. Some national body is going to have to pick one if we all going to get on the same boat with that. I like the Oxford because it's only 12. They're fairly straightforward questions to understand. It does show good variability so that, you know, it's enough, it's fine enough that you can see the improvement after arthroplasty, certainly. It's probably not fine enough to tell the difference between a good hip replacement and a great hip replacement. We'll talk a little bit about that in the talk. But right, outcome scores would be super helpful. And we use the Oxford just because it was fairly standardized, fairly quick. At one point we had a computer program they could put it into, but now we're still doing it by hand and scanning it in. And we actually have to manually go back if we want to study 30 of these patients or 60 of these patients. By manually, I mean we get on the computer and assess it, but it doesn't automatically give us updated results. So I'll hire a student from UWEC for like a project. He's for 6 months, and he'll come in and review a bunch of cases and collect the data for me. But it'd be nice would be, and there is an American Joint Registry of which we're a member here. At some point, all this data will go into one computer, and you can see it in more detail. Right now, you can get on the computer and see that people die while they're here. Did you know, things that just don't happen, right? You can't get on the computer and see, well, did they have a limp? Did they really have great function afterwards? So, great question, and a very important topic, because there is force now within the orthopedic community to come together with standardized questions, standardized evaluation, and put that all in the data that's, you know, accessible.
Well, I think that force is going to play into reimbursement, right?
Right,
It's going to come
right.
down to what you get paid for.
And right now, the reimbursement tools are very, like, very coarse. So, you know, if the person doesn't die in 90 days, you did a good job. If they didn't get readmitted for a blood clot, you did a good job. And those are really important things, but they're not looking at, did the patient really have satisfaction in terms of pain relief and function yet? But those are hopefully are down the line. In fact, the orthopedic community is like pushing for that because there's more to it than just not dying, right?
And it's interesting, you separate the orthopedic community from a physical therapy community.
Yep.
We're rocking and rolling on that.
Yep.
And we're really going to be, within the next couple of years, that's going to be a major focus. So we should try to align ourselves so that we're all using a similar tool and we're comparing the same information.
Yeah, and I think, you know, what I'll do is I'll write this down afterwards so I can email this to you. I'll show you what we're doing. We're doing on the functional side, we're doing Oxford in terms of patient satisfaction, really. And then on this other side, which is coming from CMS and reimbursement, is complications. And really that all has to do with something called risk abatement, which is a whole new topic in orthopedics, is who gets the infection, who gets the blood clot, who has a heart attack. And we have a risk abatement sheet, and that kind of plays into pre-therapy too. We have a list of about 16 things that stratify risk, and then some of those risks are modifiable. Don't smoke, don't be overweight, you know, be in physical condition before you have your surgery. So that's not the point of today's topic. It's a great topic, though. It's one of my pet topics. So afterwards, I'll get your number or email. We could get anybody who's interested, and we'll send something on risk abatement, because that's where the reimbursement's focusing now, though I'm hoping that at some point they'll look at function, too. So great lead into the talk here. So we'll start with macrorobotic hip replacement from the anterior approach. Let's see if this all works. Maybe do I need to be closer to make this go? Do I have to push the button to make it go? Oh, that thing has to go in there. Okay, we're close to making it go.
Give that a second.
There we go. So we're going to talk about fast-track recovery as an outgrowth of our changes in surgical technique and perioperative care. We're talking about the advantages of the anterior approach, which is how I do all my hip replacements now. We'll talk about methods that ensure accuracy during surgery to make sure the components are in the right place and how that plays into the minimally invasive techniques. We'll do a little bit of how the Mako robot actually works. So you're going to be able to see it over here, and we'll talk a little bit about this. And it's really not super complicated. It's similar to a lot of other industrial things. We'll talk about our initial experience with the Mako and the anterior approach, go back into the fast track perioperative care, and then go over some conclusions. So the word approach in orthopedics just means how do we get down to where we're going to do the surgery? How do we get to the hip? How do you get to where you're going to do the surgery? And so when we talk about the anterior approach, it's how we get down to the hip. Approach starts with the skin incision, and that's not showing up on that one. We'll see if it shows up on the next one. I'm not sure why that's not showing up. It was just moments ago. We have to look at the anterior approach. I'll show it on me. So the anterior approach and posterior approach. The posterior approach is in the back side. There's something called the anterolateral approach, which goes straight down the side. And then the anterior approach is in the front of the hip, and that's where the skin incision is. We're going to compare the anterior approach mainly to the posterior approach. The posterior approach was the workhorse for the last 2 or 3 decades, and we'll talk about it in comparison to the anterior approach. And I don't know how we ended up with all those not showing up.
We attached, does it have a tab internet?
No?
No.
Nope. It was just working just before we hooked it up.
Oh.
And you push play.
Yep.
Let's go back. Yeah, that's crazy.
Unless you want to start it over.
Yeah, maybe you just try starting it over. So I'll go from we'll talk about the anterior approach and posterior approach. And if you can remember, the very first slide with the picture is going to be the side of somebody's hip.
Okay.
So we'll talk more about the anterior approach. The anterior approach, we go through the front. And the first thing you'll know about the anterior approach is that patients are laying flat. So that's the supine position. At posterior approach, the patients have to be laying on their side. So they're laid up on... No, that's not. But at least it had a picture in it. So that's a good start. So go fast. Hit that one again. Yep. Yep. Let's see, and go to the beginning. See, yeah, go to play, but you still got to go to the beginning. Let me see if I can do it here. Okay, now it's got pictures. I got it. I can get us back there. Don't change a thing if we get a picture here. We don't want to lose it. And if somebody laying on their side momentarily and laying flat, okay.
There we go.
Okay, good. And I guess hit play. Let's see. Hopefully it doesn't make the pictures disappear. No, it doesn't. Okay. Sorry for that. So here's somebody for a posterior approach. So the posterior approach is done from the lateral position. So you have to put the patient to sleep or give them a spinal, roll them over on their side, and you have to get them square on their side. So you have to be straight up and down. That's actually a little tricky, as you might imagine. We're not very square on our sides. And then when we do the posterior approach, we cut through the skin, we cut through the fascia, and as your question about the tourniquet therapists are really into muscles and think a lot about muscles, and then we have to split the gluteus maximus. So we go along the fibers, we just pull the fibers of gluteus maximus apart. The largest muscle in the hip gets kind of split, at least it's with the fibers. On the deep part of the posterior approach, we have to cut transversely across the short external rotators, the piriformis, the gemelli. So there is a point where you have to actually cut across the grain for some smaller muscles. For the anterior approach, now this is a patient laying in the position for the anterior approach. They're laying supine. You can imagine in this particular patient, it would be hard to make sure that they were laying straight on their side. But we can be pretty sure they're laying completely flat. They are laying completely flat when you do the anterior approach. The anterior approach, we make a skin incision again. We cut through the fascia. And literally at that point, I take my finger and I can put it in there to guide in the next retractor. I can touch the capsule of the hip. I don't have to split through the fibers of any muscle. I don't have to cut any muscle transversely. I'm already down on the capsule. So I'm just basically putting my finger adjacent to the tensor fasciolatum muscle, and I'm right down on top of the capsule of the hip. On the deep approach, we don't have to cut any muscles. There's no short muscles to be cut. This is an extensive example of an anterior approach. We don't make that big an incision now, but we can see the hip quite clearly from the anterior approach. Not messing with the muscles, not cutting them, changes the therapy. Their muscles are coming back faster. You can use them sooner. So you can't read this whole protocol, but just suffice it to say we redid our protocol when we switched to the direct anterior approach because we didn't have to wait for the gluteus maximus and these other muscles to come around. There's some other advantages to the anterior approach. We talk a little bit about this in general. And one of the reasons I bring these things up is all of you are like your regional musculoskeletal experts, right? So patients are going to come to you and they have questions and you'll know these things now. There's less muscle damage, and that's what has driven people to the anterior approach. There's also a less common position of instability, and we'll go over that a little bit. But physical therapy for hips has always been like the 90-degree rule is like the mainstay, right? It's the beginning and the end of all physical therapy for hip replacements, and now that's gone with an anterior approach. It also leads to more accurate component positioning, even without the robot. We'll talk about that too. As you know, if somebody has a posterior approach, they shouldn't bend forward. This is the position of potential instability for the hip. As they bend forward, they're pushing the hip toward the direction in which we came into the hip. So that's why you don't want them to go into that position. With the anterior approach, you don't want them to plant their foot, externally rotate, and look up. People just don't do that. So it's really easy to have them not do that. You don't have to work very hard on stopping them from doing that. So we switched to the anterior approach primarily because we wanted people to recover faster, have less muscle damage. And we used X-ray during the posterior approach before, but what we found when we switched to the anterior approach, it was immediately obvious that we were doing a better job of getting the components where they should be. We were just putting them in a better spot. And that's because you can use the X-ray machine and get a square X-ray during the operation and be sure that what you're doing is the right thing. It would be surprising to find out that still in the United States today, in this town today, most total hips are done and they take an X-ray in recovery. It's like watching your golf shot. So you really want to see what happened, but you can't change anything, right? It's gone. So we started using X-ray during surgery, and you can get a much better X-ray if they're in the anterior, supine position for the anterior approach. Actually, when I published that, I had a fellow come from, actually 2 fellows come from China, stayed for months, gave them a good project. They looked up all these cases, and we just published that we had much more accurate component positioning from the anterior approach. So what's the effects of component positioning? It's actually important. It affects the longevity of the components. It affects the chance that the hip is going to pop out of socket. It also changes leg length. And the last thing that doctors almost never think about, we talked about assessing outcomes, muscle power and function. And if you get this well balanced, their hip is going to work better. And while component positioning is important, it's not easy with traditional methods. So this graph is somewhat complicated. I'll try to explain. It's really important. This comes from a publication from the Mayo Clinic. It could come from the Hospital for Special Surgery in New York. They have similar publications with similar results. This is the position of the cup, so the acetabular component. And we would like it to be between 25 degrees of abduction and about 45 degrees of abduction. So there's the abduction. And we would like it to be somewhere between 5 and 25 degrees of anteversion. It's actually a pretty big window that we'd like it to be in. So the box represents hip replacements where the cup was in the acceptable position. Now each one of those dots is an actual patient's cup position on that X-ray that we take after surgery. So if you look at this, there's quite a few dots in the box, but there's a lot of dots outside of the box. So this is from a great institution with experienced surgeons doing total hips the traditional way, and this is the goal that we all would accept as reasonable as hip surgeons, and we just didn't achieve it very often, or we didn't achieve it often enough. So, and there are several methods to improve component positioning. Interoperative X-ray, we mentioned that. Navigation, and then Mako robotic assist. If, like, some of your relatives call you from California, say, I'm having a hip replacement out in California, what can you tell me? You're a medical expert. How can you help me out from Wisconsin? I get this call every once in a while. I tell them, you're going to get a hip replacement. Just make sure that they're doing something. Make sure they're doing something to make sure that the component's in the right position rather than just looking at it. You just saw from a few slides before, experienced great surgeons, lots of skills, often don't get the components in the right position without some help or some additional tool to do a more accurate job. Navigation, it was similar to robotics. It was less sophisticated. The workflow was such that you had to stop during the surgery and kind of get some information from the computer and see how you're doing. If you're going the wrong direction, you'd have to stop and reassess. So we won't go into that too much. But we did use navigation here. I used navigation here for hip replacements. Dr. Berg used it a bunch for knee replacements for a while. It was kind of the precursor to robotics, which is more robust. So how does it work if you're going to get a Mako robotic hip? The patient comes to see us. We decide they're a candidate for surgery, make that decision together. We get a CT scan of their hip. And then we take that CT scan and put it into what anybody else working in like a factory here in Chippewa Valley would say is a computer-aided design program. So we put in a computer-aided design program. You sit down and you design that hip replacement on the computer, determine where all the components should be. You measure the leg lengths, you measure the offset, you look at how it's going to fit together, and you do all that before you even enter into the operating room. There we go. So here we are, sitting down with the computer and figuring out where the parts should go. And then during the surgery, and Dr. Crow alluded to this, we refer to as registering. We have to give the computer the information as to where things actually are. It has this plan now in its memory bank. And now how do you let the computer actually know where those components are. And that process is referred to as registration. So on your right-hand side, there's 3 pins put in the contralateral iliac crest. If we're doing a left hip, it's going to be the right crest. These pins go in there, so you see your patients and you're wondering why they have 3 little stitches on the other side. It's not we didn't start on the wrong side or something. But there's the holes there, and that goes onto this array. And then these dots communicate through you can see actually the robotic arm, that 2 black dots on top there of the machine, and it lets it know where things are. So that's how it communicates the position. On the femoral side, it's a little less sophisticated, but we put a marker onto the femur, and then we have a little temporary array that attaches that. We put a marker down by the patella. There's no incision by the patella. That one's just taped on really firmly. And then during surgery, the next step of registration is taking this little marker thing here. It's a pointer basically with an array on top, and we touch certain spots on the patient's bone, and then that information is sent to the computer, so it continues to build this robust image in its mind of where the bones are in space. So then you get to the point where now it's registered, the computer knows what it is. I've made my direct anterior approach. I'm going to actually just ream the acetabulum here, and you'll see how it works. I'm pushing it in there, and I'm doing the work, but the robot is holding my hand, if you will. Basically guiding to make sure that I'm on this plan that we've already planned out. So, it's probably enough of that, but okay. So, this is an important concept because computers and robotics are very precise, but they're not very robust. We all know our cell phone works great till it doesn't. Our computer works perfect till it glitches out. And the concept of this is not that the robot does the surgery. It's a concept called haptic guidance. In other words, the robot doesn't generate any force. It cannot ream the acetabulum. I have to ream the acetabulum. I have to agree that we're doing the right thing. It's what I'm trying to do, and the robot is basically monitoring what I'm doing to be sure that it's the right spot. So both I and the robot have to agree. And if we don't agree, we don't do anything. And I'll stop and see if there's a mistake or if something's wrong with the robot, we'll reassess and make sure it's right. If it somehow glitched out that day, we would just continue to do surgery like we always have, using X-ray as a means to ensure component positioning. So I think that's important. Some patients might be frightened, like you just step back and the thing does it. What if it doesn't do it right? It doesn't do it right. So that concept of haptics is really important. In fact, until they developed haptics, you could get a robotic hip replacement done in the 1980s down in California at the University of California, Irvine, I believe, where they actually had a robot and the guy stepped back and he machined the femur, and that was it. You hope it did it great because the robot was all by itself. Surgeons weren't willing to abdicate that level of control to the machine. Until haptics came along, robotics kind of stalled for almost like 15 or 20 years. Let's see, yeah, that's right. Oh, I don't want to do that twice. So here we are as we go through. You saw the part where the robot's helping me put in the cup or helping with the reaming, similarly helps impounding the cup. And then you've got the markers here in the femur. So as we do the femoral portion of the surgery, we assess where the femur is in space. So both parts get measured, and the offset and how they interact with each other gets measured carefully with robotics. I continue to use X-ray. It's like a belt and suspenders. I want the robot to tell me it's in the right spot. I want to check that with X-ray. I've got some experience with that. And in fact, we'll go into the experience here. As of October 12th, Oakleaf Hospital has done a total of 89 Mako robotic hip replacements. We've done, and I've done all of these actually, 7 bilateral total hip arthroplasties. So if you'd asked me like 4 or 5 years ago if I'd ever do a bilateral hip arthroplasty, I would have said no. Switching to the direct anterior approach made it possible to do bilateral hip replacements where patients can get both hips replaced. And of those, we've only had 1 patient stay 2 days. Everybody else has gone home in 1 day after their bilateral hip replacement with very, very few transfusion problems or anything like that. And we've done 74 single total hip arthroplasties. My own personal experience, I've done 344 of the direct anterior hip replacements. 68 of those ones that we talked about I have done of the robotic hip replacements. And we continue to monitor our results. So we look at things like our Oxfords, and we look at our 6-week standing X-ray and compare that to our immediate intraoperative X-ray and see how those things compare. So we're going to measure this, and at some point I'd like to compare direct anterior X-ray guided hip replacements to robotically guided direct anterior hip replacements. So how does it work in the rapid recovery program? Like I said, it's not that we want patients to go home sooner than when they're ready. We just want them to be ready to go home sooner. We want them to feel better sooner. Part of that's how we treat them perioperatively. One of the reasons we don't give people PCAs anymore is they wake up numb. So we numb up their hip during the surgery so that they don't have that immediate burst of pain when they first come out from anesthesia. They don't feel like way because it's numb. Just like you go to the dentist, it's numb. We give them scheduled Tylenol. We give them a scheduled amount of narcotics. So they get a little pain medicine before they start, so some pain medicine is in their system. So again, it's like hitting your hand on the stove, right? Once you burn your hand on the stove, every little pain just gets you. If you never let them get that one burst of intense pain, they never get, worried about pain. They never get concerned about pain. They just never get that much pain afterwards. I've had several patients who are intolerant to narcotics have zero narcotics post-op. Nothing. So, and they've done pretty well. It says it feels like a bruise. We use cold therapy. We use compression therapy. We started doing the multimodal pain control a few years ago, and actually all that was left that was holding people back was nausea. And so in the last couple of years, we've really gotten into trying to prevent the nausea. It turns out that when people get done with anesthesia, most of them are hypovolemic, and that's what makes them dizzy, and that can make them a little sick to their stomach, so everybody gets a fluid bolus. We use a scopolamine patch to reduce nausea. We give them antiemetics, IV antiemetics, before they get sick to their stomach. We just treat that right off the bat. Aggressively mobilize them. We want them walking within a few hours of arrival to the floor, preferably within an hour. So they get up to the floor, the nurses take their vitals, they get everything set, and they get them up and get them walking soon. And we want to walk a few hours, every few hours while they're awake there. It used to be you got up once after surgery. You might get done with surgery, you get up to the floor at noon, you walked at 2, and you sat there till 10 o'clock, till you went to sleep, and waited until 8 o'clock next morning to get out of bed again. So looking at discharge, what's the impetus for going home? I told you about a few patients who wanted to go home the same day. We weren't really set up for that. This is what we're currently doing with my Mako hip replacements. 64% go home on the first day, 26% go home on the second day, and 10% stay to the third day. And I can tell you almost every one of those people staying to day 3 are older people who need to go to rehab. And as you know, Medicare requires them to stay 3 midnights before they can go to rehab. The other thing I'd mention is that of these people going home on post-op day 1, very, very, very few of them are going to rehab, pretty much 0. So these aren't people just switching their away-from-home experience from the hospital to rehab. Most of these people are going truly home, not to Dove South or to some other, or to another place for rehab or swing bed. They're going all the way home. In conclusion, some things that I think are important to remember. Therapy restrictions are dictated by the surgical approach. So whether somebody has a robot or not, it's not quite as important as whether they have a direct anterior approach or a posterior approach. That's the position of instability is determined by the approach. And both a direct anterior and a posterior approach would benefit from some of the same things we do for rapid recovery. So pre-therapy is a good idea for everybody. Getting these things figured out ahead of time doesn't hurt no matter how you're going to have the surgery. So if you're learning this for our patients, you get patients from another hospital, another facility, it doesn't hurt for them to go through a lot of the same things you're going to learn for rapid recovery. Outpatient therapy is critical. Obviously, you're going home the same day or the next day. You haven't had a lot of therapy while you're in the hospital. You need to get therapy as an outpatient. And to continue with our summary here, fast-track recovery is made possible due to the anterior approach, in my opinion, and multimodal pain control. The approach affects the recovery and post-op restrictions. The robot lets us do a very accurate job of surgery through a very small incision, enhancing our ability to do rapid recovery. And we're going to see more patients who are younger, healthier patients are probably going to start going home the same day. And what I think for hip replacements, we won't ever see them. If you'd asked me several years ago, I wouldn't have said most people can go home after 1 day. But I don't think we're going to see most people going home the same day. I think we'll see a percentage of them going home the same day, and pretty much everybody going after 1 day unless they have some type of insurance requirement for rehab and they don't have any person at home to help them at all. And in conclusion, it's basically the trust that the patients put in all of us that drives us to do the best that's humanly possible. So it's okay, it was okay to do hip replacements the way we did them before, but patients are coming to us and they want us to do the absolute best job that we can. And it behooves us, in response to that trust, to continually do the best job that we humanly can. Any questions? Anything I can answer for you? Yes?
What are some things that might make you go back to a posterior approach versus choosing an anterior approach?
That's a really good question. So in my practice, 99.5% of people get an anterior approach. So the people who can't get an anterior approach are the people who have a pannus that hangs over all the time and that skin breaks down. So if you have a skin breakdown underneath the pannus, I don't want to cut through that tissue. Those are the only patients I currently would do through a posterior approach for a primary hip replacement. Now, the reason that's probably an interesting question, because there are a few surgeons in town who selectively do the anterior approach, maybe 1 out of 5 times, and they'll tell people, well, you're not a candidate for the anterior approach. What they mean is that I'd rather do a posterior approach on you because it's going to be maybe a little bit more difficult, or I just prefer doing the posterior approach. So there really isn't anybody whose skin is intact in the front of their hip that can't have an anterior approach. And then the people who have a pannus, there are people who have a pannus who don't have skin breakdown, right? If there's a person who comes in and they have a pannus that covers the entire incision, which, is a third of the way down their thigh, I'll say, look, if you can just keep some cloth tucked underneath that consistently, you can have an anterior approach. And then the other thing about the anterior approach, for those patients who have some skin hanging over there, we don't we close the wound differently than we used to. So what we do is we seal the wound with something called perineal, which is basically glue plus a fiber that's embedded in it. It looks like burlap with glue in it. And that way, even if there's some moisture, it doesn't get to the wound. So that change is really critical. If you look at some of the early literature on the anterior approach, one of the controversies was more wound breakdown and more infections in obese patients. They weren't doing this wound care. They weren't sealing the wound, and they weren't keeping some type of cloth material there. And then there's some people, heavyset people, they tell you you're going to do that, not going to do it. You have to trust them. But we've had very good luck, even in people with a pannus that covers a portion of the wound, not getting wound breakdown, not getting infection. So it's a great question, a little controversial. But if you look at people who are high-volume hip surgeons, who do primarily hip surgery, who do primarily anteriors, they're going to tell you that 99% of people are a candidate for anterior approach. Great question. Yes?
Do you use the robot with all of your anterior approaches, or how do you decide when to use it, when not to?
All of my anterior approaches that I do here. Now, so the robot is an investment for a hospital in terms of money and time. The staff have to know how to use it and they have to put some energy. Currently, in western Wisconsin, this is the only hospital that has a robot. Now, some patients, if they have comorbidities, they have to have it done at Sacred Heart St. Joe's, where I also do surgery. Then I go back to doing multiple x-rays. And I think then the anterior approach, as we said, is really helpful because I know I'm getting a square x-ray. So right now I would say about 60% of my hip replacement business I do here. About 40% is mostly at Sacred Heart, but some at St. Joe's. And in those patients, I'm back to just using the x-ray. And it has to do, we don't have a cardiac ICU or all the things here that you might potentially need if you have other medical issues, though most of the time those aren't a big deal. But it's basically dependent if they're done here. If they're done here, I do it with the robot, every single one. It's a good question. Great question.
Do you have a new research box on your Mako?
As
far as hitting your mark on your Mako?
You mean like, say again, if I understand the question about...
Your boxes.
Oh, yeah, so that's exactly, have we looked up on the Mako to see how we are in terms of fitting within that box? That's a great question. Not yet, but I'm going to, and I'll tell you that it depends now, when we're getting this precise, depends on how you measure it. Because if I were to measure it based on my intraoperative x-ray and the Mako, they're all in the box. No question, because we're using the measuring tool as we're doing the surgery. So then the question becomes, is that the most representative way to measure that cup position? We never used to even talk about this. When they did those studies, those were mostly standing 6-week x-rays. They're standing up at 6 weeks. You tell them to stand in front of the x-ray. We take a picture, and we measure off of that x-ray. Some of those, though, they would take the x-ray when they were just laying, in the post-op recovery room and take an x-ray then. It turns out that the position of the pelvis can change subtly. When you're looking at a 25-degree window, we didn't even care how we were measuring it, because when it was off, as you can see, like 30 or 40 degrees. But now when we're trying to get as precise as we are, if the Mako says 43 degrees, and is the 6-week standing x-ray going to say 47? Is it going to say 39 because of a little slight shift? We'll have to see. But in terms of, if we were to do that box off of intraoperative x-ray and off of Mako, they're 100% in the box. In fact, the box has gotten tiny. We decided at the beginning of the surgery, do we want 40 degrees? Do we want 43 degrees? Do we want 45 degrees? And when we're done, it holds it to, you can't pound it in at a different degree. It goes in at exactly that degree. So we're going to compare our intraoperative box, which is going to be tiny, and see what little bit of scatter we get once we have people standing up. Like that other question, this is a lead into one of the hot topics in orthopedic surgery, which is pelvic mobility. So you can take some patients where their cup may look one way when they're standing. You can take an x-ray, straight on. You have them lay down, and now the cup seems to have shifted 10 degrees. Well, the cup hasn't moved. The position of the pelvis relative to the long axis of the patient has changed. And with these historical studies where we say the ideal cup position is here, we didn't have enough precision to make these 5 and 3 degree measurements matter. We're going to have to start deciding is the cup position when you're standing more important versus when you're laying down versus, the ASIS. Another way to measure it is to measure the actual positions on the pelvis, create a plane, and then use that plane for reference. So right now, if the box is based on intraoperative X-ray, and that, it's right there. It's within degrees. Good question.
Based off of that, why don't you guys, or would it be possible to do pre-op X-rays in standing and supine to see the difference in the pelvic mobility?
Yeah, that's exactly what we do. So what we do now is we take a 6-week standing X-ray. So when I'm in surgery, this is like I planted these people, and this is great. So we take what we do during surgery is I'll have the Mako robot, which is based on a supine CT. So when you get to CT, you are laying flat, and that picture you see over there on the right, that's the patient laying flat. And in the operating room, I still have their standing AP pelvis X-ray. And what we do is we look at the obturators, which are those 2 little black, if you could, Marty, point out the obturators there, those 2 little black dots. Now, as your pelvis shifts a little bit, the morphology, the shape of those obturators change. And so we use their standing 6-week X-ray relative to their supine CT to try to gauge where they want to be. Now, most people, they're not that different. But if we still think we have a 20-degree margin of error, that's not a problem. Where there can be a huge difference is people with substantial spine pathology. So there are people with a very stiff spine that when they stand, it really shifts the position of their pelvis, or ladies with scoliosis and other people. So there are some people in which we'll say the robotic ideal has to change. We can't use 40-20 if we know when they stand, they change substantially from the supine. So we can then change what we want to do versus their supine reference based on what we see on their standing film. So it's a great question, really, really interesting. Before, when we were like, well, we hope we're within 20 degrees, we weren't doing that. But now when we know we can be that precise, we're looking at exactly those factors. It's a good question. Yes?
If you're doing, this is kind of an anatomical question, but if you're doing an anterior approach hip replacement and someone who's had a previous inguinal hernia repair and they've got mesh and scar tissue and things like that, does that preclude you from being able to do an anterior approach, or do you have to change the procedure?
Good question. So I'm going to repeat that because I'm supposed to repeat the question so everybody can hear. The question is if they've had a hernia repair and they have mesh. Actually, there's a correlated question that if they've had a vascular repair, I mean, the femoral artery can be operated on right in that area. Does that change our approach? And the answer is no, because we're about 2 or 3 centimeters lateral to where the hernia would be, and 4 or 5 centimeters lateral to where their vascular approach would be. So I've done a number of patients with mesh hernias, absolutely no concern. I was a little more concerned when people had, they have vascular grafts, right? They have a aorta bifem, and it's going to get pulled up a little bit while we're doing the direct anterior approach. We put a retractor on the top of the acetabular, you're going to pull up on that graft. But if you look at the posterior approach, we actually, we kink it, right? We kink it, we twist it 180 degrees, and we bend it 90 degrees. I think actually probably less trauma to the graft, the aorta bifem, and probably less trauma to the hernia with the anterior approach and the posterior approach. But we have done patients in those situations without problems, and we're just far enough away that we're not going to interfere with where their hernia surgery was or where their aorta bifem was. So, great question. Other questions?
Can you speak a little bit, Dr. Stewart? Obviously now Mako is associated with the Stryker components. As a surgeon who maybe you like Stryker, maybe you didn't like Stryker, J&J, you're kind of locked in. Can you speak a little bit how the industry is handling that?
Yeah, that's a great question. So the question was, Mako now was bought by Stryker. So if you're putting in a Mako hip replacement or a Mako partial knee replacement, now it's a Stryker component. And that's actually a huge question. If we look at the last, I've been doing this since 1992, the biggest problems have been component problems, right? So I did do Stryker hip replacements before, so it wasn't a change. And if you looked at hip replacements in terms of geometry now, and I set the top 3 leading companies, top 3 hip replacement sellers, you could hardly tell them apart. I mean, in terms of geometry, they're the same. And what I think is important is that whatever you're using, if you're using a Stryker hip replacement, J&J, or Zimmer, that you have a model that has good 10-year, 7 to 10-year data. If we look at the model which I do now, which is a titanium stem with a ceramic head, on a titanium cup with a high molecular weight plastic liner, we have 97% 10-year success in that model. I'm not interested in changing that until somebody else comes up with something new that they've had out new for 10 years and the data looks, as similar. If you look online, pretty much every major orthopedic company has had failures. I mean, Stryker's had failures, Johnson & Johnson, DePuy's had failures, Zimmer's had failures. And those failures don't become evident until, 3, 4, 5, 7 years after the implants come out. So I'm happy because I'm using a Stryker component that I know has been out for a decade, and I can trace how it's done for a decade. And if Stryker or anybody else comes out with a new component, I wouldn't want to switch to that until they had quite a bit of data. You go back before Stryker bought Mako, Mako wasn't that popular because Mako had its own implants. So if you used the Mako before Stryker bought it, you had to put in Mako implants. And Mako was a very small company. Their components didn't have a track record. They really came out about the time Johnson & Johnson's DePuy hip was having all its problems. There weren't many orthopedic surgeons who said, yeah, I like the robot so much, I'm going to go to a completely unproven implant. So implant choice is critical. Actually having one of the major three buy Mako has allowed more surgeons to have confidence in using it without having to go to an unproven implant. So Mako was stalled. I don't know if you have people with Mako history here that can counteract that. And Marty could talk to you afterwards because he was a Mako guy. But I thought Mako was somewhat stalled by the fact it wasn't aligned with an implant that had a track record. That's a great question. Other questions? Otherwise, I'll let Amy start talking and get to the meat of it. What we're really here is to talk about therapy and how therapy can help fast track. But I'll stay here afterwards if there's other questions, and I'll be happy to give people a little tour of Oakleaf when we're done. We'll just kind of gather over here by the food when we're done, and if people are interested in seeing the building, we'll show you around. Thanks very much for your